Hi, I'm Dr. Tom Kravis, Physician Executive for 3M Consulting Services. Thank you for joining me. Today we're going to talk about ICD-10 documentation for ENT and ophthalmology. There are some changes you'll need to make in your documentation to support ICD-10, but there are instances of documentation that can remain the same. Let's get started. By the time we're finished, you'll have a clear view of ICD-10. I know you are busy in your clinical practice, so I will briefly summarize the key takeaways. In your documentation of patient care, consider the use of adjectives. Link the cause and effect of each condition. Be specific about aspects of a disease and each anatomical site, and use exact dates when appropriate. A little more on each of these. Differentiate in your notes whether or not a condition is acute, chronic, or acute on chronic whenever appropriate. For example, write acute otitis media rather than otitis media. Use due to or secondary to indicate cause and effect, and to record all conditions the patient may have, such as glaucoma due to steroids. Think about the most current terminology to describe a condition or different aspects of the disease. For example, vasomotor rhinitis. Precisely designate anatomical sites. For example, document acute maxillary sinusitis rather than sinusitis. Ask yourself, what else could I add in my notes about this patient's condition that would better communicate how sick the patient is, which in turn better communicates the resources needed for patient care. Incorporating these aspects into your documentation will result in an accurate picture of your patient's severity of illness and risk of mortality. This in turn will result in accurate public reporting on quality and outcomes. And it will help reduce the number of queries you receive to clarify your documentation. In the upcoming slides, we'll take a look at some diseases and procedures that have new documentation requirements under ICD-10. In ICD-10, there is a feature called Laterality for right, left, and bilateral, which is found in many diagnoses and procedure codes involving paired organs, or those codes specific to one side of the body versus the other. For example, acute left otitis media. ICD-9 had a limited number of these. ICD-10 has many more. This feature of ICD-10 by itself is responsible for a substantial increase in the number of codes which you have probably heard so much about. Since you usually include this information in your patient care notes, additional documentation will typically not be needed. So for your information, if you happen to omit laterality when needed, it may result in a query. Most all codes for conditions affecting the eye and ear have separate codes in ICD-10 for right, left, or bilateral. So do a quick double check of your notes to be sure you included it before signing off. We try not to belabor this point in the upcoming slides. As I am sure most of you listening today may be aware, the diagnosis and management of acute otitis media has significant impact on the health of children, cost of providing care, and the overall use of antibiotics. The illness also generates a significant social burden and indirect cost due to time lost from school and work. The more specific we can be in reporting this diagnosis, the better the data will be that is used to quantify the impact on children, costs, burden on the healthcare system in general, and to determine efficacy of treatment. New to ICD-10 is the ability to capture recurrence in acute suppurative otitis media and acute non-suppurative otitis media. Take a few minutes to review on screen the types of otitis media that are separately identified in ICD-10 and the additional documentation for each that, when provided, will result in the reporting of an accurate description of the condition you are treating. Note that the terms you see, such as acute, chronic, recurrent, allergic, and serous, for example, must be documented by you in order to report these specific codes. Classification of mastoiditis remains unchanged in ICD-10, with the exception of the ability to report laterality. You still have the ability to report, when documented, acute mastoiditis without complication, subperiosteal abscess of mastoid, and other complication of mastoiditis, and chronic mastoiditis. Also, coding of cholesteatoma and cholesteatoma as a complication of mastoidectomy is mostly unchanged, with the exception of laterality. One minor change. ICD-10 now has a code that identifies cholesteatoma of the tympanum. There has been a change in the terminology in ICD-10 to describe Ménière's disease. As you can see in the ICD-9 and ICD-10 codes on screen, the terms for active or inactive Ménière's have been dropped. So in ICD-10, you either have it or you don't. Also, note that the disease is no longer differentiated as cochlear or vestibular or a combination of both. Laterality is the only additional documentation needed. ICD-10 classifies conductive, sensorineural, and mixed hearing loss as bilateral or unilateral with unrestricted hearing on the contralateral side. A distinction is no longer made for conductive hearing loss of the tympanic membrane, middle ear, inner ear, or of combined sites, as was the case in ICD-9. Nor is there a designation in ICD-10 for asymmetrical sensorineural hearing loss. On screen are two examples of codes illustrating bilateral sensorineural hearing loss and unilateral conductive hearing loss of the left ear with normal hearing on the right. The bad news is that while ICD-9 has a code that specifically described Eustachian tube dysfunction, ICD-10 does not. Specific Eustachian tube disorders described in ICD-10 are acute or chronic Eustachian salpingitis, Eustachian tube obstruction, further described as intrinsic or extrinsic cartilaginous or osseous, and finally, patulous Eustachian tube, the latter being admittedly somewhat rare. So specify the cause of the Eustachian tube dysfunction when known or suspected. Otherwise, Eustachian tube dysfunction is reported with a code that only states other specified disorders of the Eustachian tube. And don't forget the right, left, or bilateral. What's new? ICD-10 provides a new code J30.0 that specifically identifies vasomotor rhinitis. Previously in ICD-9, a diagnosis of vasomotor rhinitis was classified to a code that stated allergic rhinitis unspecified cause. As in ICD-9, ICD-10 continues to classify rhinitis into three categories: acute, chronic, and allergic. The allergic category is now renamed vasomotor and allergic to accommodate the new code. Remember, the more specifically you document your patient's condition, the better the story you tell. Take, for example, a diagnosis documented as rhinitis versus a diagnosis documented as acute vasomotor rhinitis. Which story is better? On screen, you see that code J31.0 for chronic rhinitis is reported when you document only rhinitis. Rhinitis defaults to chronic rhinitis, versus J00 and J30.0 when you document acute vasomotor rhinitis. What's new? New in ICD-10 is the ability to report when documented when sinusitis is recurrent. Also, there are new codes that specifically describe acute or chronic pansinusitis. What stays the same? As in ICD-9, sinusitis not otherwise described by you in the medical record is coded as chronic sinusitis. So if your intended diagnosis is acute sinusitis, you must document acute. You should also document the specific sinus or sinuses affected because unique codes are reported for maxillary, frontal, ethmoidal, and sphenoidal. As previously mentioned, when your diagnosis is acute or chronic pansinusitis, a code can be assigned that says exactly that. The look and feel for codes describing diabetic eye disease have changed, but the level of detail describing the disease remains mostly unchanged. This means that your documentation doesn't need to change as long as you are currently documenting the type of diabetes as type 1 or type 2, because the codes are different, and you are using terms to specifically describe aspects of the disease. For example, mild, moderate, or severe non-proliferative diabetic retinopathy and with or without macular edema. Unlike many codes for conditions of the eye, laterality is not a component of the codes for diabetic eye disease. The good news is that ICD-10 uses single combination codes to describe the disease, where ICD-9 usually required multiple codes. Take, for example, the diagnosis of type 2 diabetes with moderate non-proliferative diabetic retinopathy with macular edema. This diagnosis required 3 codes in ICD-9, but in ICD-10, all of this is reported in a single code. By a healthy margin, the most reported cataract code in ICD-9 is the unspecified senile cataract code. In ICD-10, the code is just as vague. It just uses the term age related instead of the term senile. Unlike other ICD-10 cataract codes, it doesn't even allow the coder to report which eye has the cataract. If you know or suspect the type of age-related cataract at the time of the patient encounter, you should include this in your notes, such as incipient, cortical, anterior or posterior subcapsular polar, etc. These subtypes are similar to the ones available in ICD-9, just expanded for right or left eye or bilateral. The change in the terminology in ICD-10 used to characterize vision impairment is significant. Gone are the terms such as moderate, severe, or profound impairment. In ICD-10, there are 2 clear, simple distinctions. You are either blind or you have low vision. The definition of low vision is easily located in the ICD-10 codebook at code H54.8. Here you will find a table listing categories of visual impairment with associated visual acuity with best possible correction. Low vision comprises categories 1 and 2 in the table. ICD-10 codes are available to describe blindness in one eye and low vision in the other, and all other combinations. On screen are 3 code examples. Finally, the code for legal blindness, as defined in the USA, crossed over from ICD-9 unchanged. ICD-10 has greater specificity for anatomical sight and usually requires documentation of laterality for paired organs. Be sure your documentation is as specific as possible when identifying anatomic sight. Unchanged from ICD-9 is the classification of malignancies as primary or secondary, which is a particularly problematic area of documentation for coders. Often, primary or secondary is not specified, and in the case of secondary malignancies, whether the primary site is still present. A statement of history of can be ambiguous and may prompt a query. For example, appropriate documentation of a malignancy would be metastatic cancer to right ciliary body from breast. Patient underwent mastectomy 1 year ago, and there is no evidence of recurrence. This documentation clearly identifies the primary and secondary site and states the primary site is no longer present, all of which are factors considered in code assignment. It is appropriate to state primary site unknown or to state a diagnosis as possible or probable. As physicians are increasingly held accountable for patient outcomes, a huge concern is how to classify the patient who fails to follow a recommended regimen of care and gets sicker as a result. Under ICD-9, there is only one generic code for such a patient that says non-compliance, and no additional detail as to why the patient didn't follow your instructions. But in ICD-10, there are several codes to describe why a patient is non-compliant in taking drugs prescribed by you. This new clinical terminology is drug underdosing. Underdosing identifies situations in which your patient has taken less of a medication than prescribed by you, either unintentionally or intentionally. Document in your notes why the patient isn't taking the correct amount of their medication and the associated condition. For example, patient did not take the entire course of antibiotics because she felt better and didn't think she needed to take the rest. ICD-9 provided a single code for tobacco abuse and dependence without differentiation and without further specificity for the type of tobacco product. ICD-10 provides separate codes for these. If your intended diagnosis is dependence, dependence is what you should document rather than abuse. According to the Centers for Disease Control and Prevention, most smokers are dependent, and nicotine dependence is the most common form of dependence in the U.S. Additionally, further specificity is provided in ICD-10 for the type of tobacco product dependence, as cigarettes, chewing tobacco, or other, for example, cigars, so this should be documented as well. Your documentation should differentiate between current abuse or dependence versus a person who no longer uses tobacco. Starting in 2002, the number of former smokers has exceeded the number of current smokers. For tobacco dependence, ICD-10 provides the ability to report remission and withdrawal. Examples of nicotine withdrawal symptoms include irritability, anxiety, difficulty concentrating, and increased appetite. ICD-10 also provides the ability to show a cause and effect relationship between tobacco dependence and nicotine-induced disorders when documented. Finally, your notes for a patient's exposure to secondhand smoke can be converted to an ICD-10 code that says exactly that. In ICD-9, codes for complications did not identify when the complication occurred, the body system affected, or type of surgery performed. ICD-10 codes do. In order to code a complication, the coder must know whether the complication occurred intraoperatively or postoperatively, so include these details in your notes when it is not readily apparent. Additional elements needed for code assignment, which the coder should be able to determine from the record, are body system of organ affected and body system on which the procedure was performed. For example, accidental puncture of the retina resulting in a retinal tear during eye surgery is assigned to H59.211. We'll take a look at a few procedures that may be performed to give you some exposure to ICD-10 PCS codes and associated documentation requirements. ICD-10 PCS has specific definitions for these two different procedures. A code for excision is used only when a portion or part of an organ or body part is taken, for example, removal of a nasal polyp. Resection is taking all of a body part, such as tonsillectomy and adenoidectomy. This can be particularly problematic for the coder when your documentation is not precise or is ambiguous. Take, for example, surgical removal of lymph nodes. Resection is assigned when an entire lymphatic chain is removed. Excision is assigned when several lymph nodes are removed, but not the entire chain. So document precisely what or how much of an organ or body part is removed. You don't have to use the words excision and resection according to coding definitions. The coder will apply the definitions based on your documentation of what and how much was surgically removed. Take, for example, laryngoscopy with resection of vocal cord polyp. Although the physician documented resection, the coder will assign a code for excision, since only a portion of the body part is removed. Here you see the table the coder will use to construct the code for this procedure. The first 3 digits of the code come from here, indicating an excision procedure on the mouth and throat. The next digit of the code captures the specific body part, in this case, the right vocal cord. The approach via natural or artificial opening endoscopic is selected for laryngoscopy. No device indicates a device was not left in the body, as would be in the case, for example, for insertion of ear tubes. Finally, without a statement by you of biopsy or indication the procedure was performed for diagnostic purposes, the coder will select Z, no qualifier. The resulting code for the procedure is 0CBT8ZZ. Let's look at a couple more procedures and see how they are coded in ICD-10. Take, for example, insertion of cochlear implant of the left ear. Here you see the table the coder will use to construct the code for this procedure. The first 3 digits of the code come from here, indicating an insertion procedure on the ear, nose, and sinus. The next digit of the code captures the specific body part, in this case, left inner ear. The approach selected is open. Character 6 in the device column specifically identifies the multiple channel cochlear implant. It is important that the type of the device you insert is documented in the medical record. There are no qualifiers for this procedure, so character Z is selected. The resulting code for the procedure is 09HE06Z. Take, for example, penetrating keratoplasty of right cornea with donor-matched cornea percutaneous approach. Here you see the table the coder will use to construct the code for this procedure. The first 3 digits of the code come from here, indicating a replacement procedure on the eye. The next digit of the code captures the specific body part, in this case, right cornea. The approach selected is percutaneous. Character K in the device column specifically identifies the donor-matched cornea as non-autologous tissue. There are no qualifiers for this procedure, so character Z is selected. The resulting code for the procedure is 08R83KZ. ICD-10 requires more detailed descriptions in your documentation of anatomical site and aspects of a disease, condition, procedure, and circumstances of patient encounters. The information generated from ICD-10 codes will result in a more accurate picture of your patients, their severity of illness, risk of mortality, and the services rendered. This in turn will result in accurate public reporting on quality and outcomes. Should you have questions about documentation for a particular diagnosis or procedure, your hospital's clinical documentation improvement specialist should be your first stop. The coding staff in your Health Information Management Department is a valuable resource as well. Thanks for joining me, and have a great day.